to the presentation by our senior consultant. So I will be introducing our second speaker, Dr. Samuel Kwar. He is one of those senior neurosurgeons in our setup. He's one of those brilliant surgeons, I would say. He was my mentor, and currently he's also
Did you hear
my
me?
Dr. Semenyo, is that
Yeah.
you? All right. Pardon the interruption again. I think our first speaker is here. Dr. Semenyo, can you share your screen with us?
Yes, I get it.
All right. Dr. Semenyo is a resident from one of the training centers, which is Black Lion Hospital. And today he'll be presenting a case and giving us a discussion on carotid cavernous fistula, which was managed in their center. Dr. Semenyo, right now, I think you can share your screen and proceed with your presentation. Can you do that?
Is that visible?
It's loading. Yes, now it's visible. Can you make it on a slideshow so that?
So my name is Dr. Samanyo.
Perfect, perfect.
Great, you can proceed now.
So my name is Dr. Samanyo, and year 5 neurosurgery resident from Black Lion Hospital at the Kurambasa. So today we have one case based discussion on direct carotid cavernous fistula. So this patient is 34 years old, male patient. And the clinical presentation was 34 years old male patient present in left side progressive left side proptosis serious duration with rectal pain, and shows having sustained traumatic accident fall in stomach and shows claiming visual transit loss of vision loss for the last 5 months, otherwise no history of weakness, and there is no current visual complaint as well as headache and epistaxis. So upon presentation on physical examination shows have left side versatile prosthesis with bruit auscultation, and neurologically this is also 15 out of 15 and close mid-size reactive bilateral, and shows having visual acuity of tongue count from 6 meters bilateral and other cranial nerves be intact, and the power was 5 out of 5 in all extremities. So shows having basic investigation as well as so this patient was having both CT angiography as well as digital subtraction angiography. So the baseline
Ruslan, can you hear that okay?
investigations are with a normal range, and on CT angiography dilated cavernous sinus with dilated superior orbital vein, and there is also some communications between intercavernous sinus, and the patient is also having torsions in the dilated superior orbital vein with exophthalmos, and this sagittal view, as we see from this image, shows significant exophthalmos with dilated superior orbital veins and dilated torsions left side cavernous sinus, and this is also another view from the coronal image. So in conclusion, CT shows dilated and torsions.
I think there is an echo because the colleague must be connected from 2 different devices, and that's why we hear the echo.
Yeah, if you can get off all your programs other than the YouTube, other than Zoom, okay?
So in general, I mean,
Yeah, you're on 2 programs. On your computer, get off all your other programs besides Zoom.
So
Okay.
CTA shows, now it's corrected, right?
Yeah, that's better.
It's fixed. So
Let me know, Irusula, but it's okay, the sound, okay?
okay. So CTA shows dilated interface left cavernous sinus with dilated left superior orbital venous with exophthalmos and shows of having digital subtraction angiography. So we have both sagittal as well as from coronal, and this one is with internal carotid artery injection on the right side, on the left side, and it shows both internal carotid artery as well as M1 as well as M2 and A1 with APOM and with A2 bilateral on the right as well as on the left side. And from this image, it shows on the right side internal carotid artery injection view. So there is cross filling from the right side to the left side, and you can see from this image both MCA as well as AC bilateral from the right as well as the left, and there is also a communication through ACOM. And this is another image, and we have also common carotid artery injection views, both the external carotid artery as well as the internal carotid artery. So there is no any abnormality from the external carotid artery view from this digital subtraction angiography. So there is tortuous and dilated cavernous sinus with dilated superior orbital vein on the left side from this digital subtraction angiography on imaging. So in conclusion, this shows direct left carotid cavernous fistula with retrograde drainage primarily to left side superior ophthalmic vein via intercavernous communication with additional outflow to the left internal jugular vein, and right ICS supplies cross filling both sides through ACOM. So for this, we do transarterial coil embolization, and we use 5 French 10 centimeter sheaths and 125 centimeter vert catheter over 108 centimeter vert tip wires, and we use 3 onyx coil. So this is after we do the procedure. So these are the post transarterial coil embolization. So there is also decrease the lateral borders of the ICS are seen as occluded, and there is no significant retrograde flow of the blood through the superior orbital veins in this last image. So shows having preoperatively photos from the patient. So as we see from this image, the patient was having significantly proptosis with IDP demo, and these are after 3 months durations of transarterial coil embolization. So to say something about the direct carotid cavernous fistula, this is abnormal shunt or communication between internal carotid artery as well as cavernous sinus if it is direct, and in case of indirect types of carotid cavernous fistula, there is a communication between cavernous sinus to the artery, either external carotid arteries or internal carotid arteries through the branches. So these are as classified as high or direct high flow, as an our patient shows having direct high flow sense from the cavernous sinus to internal carotid arteries. And in case of indirect, there will be a communication through the medial branch either from the internal carotid arteries as type B or from the medial branch of external carotid artery as considered as type C, and the type B is it can be both from the IC as well as AC to the cavernous sinuses. So these are very important for the management purpose. Thus we use transarterial or transvenous embolization or to follow the patient conservatively if the patient are on medication for surgery. So sometimes in case of indirect types of carotid cavernous fistula, we can also use clipping from open neurosurgical perspectives. So these are other classifications, as we said previously. And so clinical presentation as our patient, the patient can be presented with ecchymosis as well as pulsatile proptosis, since there is significant blood shift from the internal carotid arteries to the cavernous sinus. So there will be a shift of transmissions of arterial pulse toward the superiorbital vein towards the globe, and the patient can also have orbital as well as retroorbital pains and ocular as well as cranial bruise, and the patient may have, especially in case of direct carotid cavernous fistula, the patient may have history of trauma, either road traffic accidents or stabbing injuries, since our patient was having history of road traffic accident for Shabak. And the other, the patient can also present with deterioration of visual acuity, especially if the patients are complicated with subarachnoid hemorrhage or retrobulbar hematoma. The patient may have visual acuity decreasement, as well as the patient may have developed diplopia, and absent nerve or cranial nerve may also be affected in case of significant shifts in or dilations of carotid, cavernous sinuses. And the other, the patient can also presented with cerebral subarachnoid hemorrhage or neovascularization in iris or retina can also be presented. So, as diagnostic principles, the patient should have both basic investigations as well as diagnostic investigations, especially renal function tests are mandatory in order to prevent retinopathies from the contrast injection, and you have to know the baseline investigations, including renal function test as well as liver function test and electrolyte with CBC profiles. So in case of CT angiography, we can see dilatations or abnormalities from the cavernous sinus or any communication between cavernous sinus as well as arteries, including the internal cerebral arteries and as well as internal carotid arteries or external carotid arteries, or the meningeal branch can also see from CT angiography. And in case of digital subtraction angiography, you can see the size of the fistula as well as the size of the fistula to know the size of the coil, as well as to select our approach can we use for transarterial or venous approach, or sometimes in case of indirect can also use for the open aneurysmal clippings. So the other is there are some indications to do surgery for such type of patients, and if the patient develop sight proptosis, visual loss, or cranial nerve palsy, and if the patient develop interactive, it means the patient needs surgical intervention, either open or endovascular, with the gold standard, especially for indirect types of fistulas or endovascular approach. So these are the option of management. So either conservative, especially if the patients are not symptomatic, in indirect types of fistula, and the patient is not symptomatic, we can follow or we can manage conservatively. And if the patient develops the previous symptoms, we can do endovascular, and in case of indirect, there are some places for open vascular clippings. So thank you for.
Right. Thank you so much, Dr. Semenyo, for the very interesting case that you've presented for us. For the sake of our time and to make the discussion and Q&A session at the end, we should proceed to the next presentation. You can stop sharing your slides now, Dr. Semenyo. The next speaker is Dr. Samuel Ikwar. He is a neurosurgeon and an assistant professor at St. Paul Hospital Millennium Medical College. Dr. Samuel has a lot of interest in neuro-oncology and skull base, and majority of his cases that are being that he's performing right now usually is neuro-oncology and complex skull base tumors. But today he has agreed to give us a talk on his experience on low-grade glioma surgeries. Dr. Samuel, you can proceed. Thank you for being here.
Thank you for the warm introduction, Dr. Yerusalem. Thank you, Neurosurgical TV, for having us. I'll just go through it. Is there any problem with the audio?
Oh, it's perfect. Perfect.
All right, so I'll try to go fast. So this will be the outline of my presentation today. First, I'll go on general remarks on low-grade gliomas, and then we'll go through some of the lessons that we learned from our own local practice. And then finally, if we have time, we'll go through some case examples and surgical videos. So I work at St. Paul's Hospital, Millian Medical College. It's a very old hospital established in the 60s. This is the old building, currently undergoing very rapid expansion. We have a lot of new complexes now being built. We take care of we handle more than 200, 300,000 cases per year, the general hospital itself. And we do treat patients from all over Ethiopia. So I'll start with the definition of low-grade glioma. In the old days, there are different definitions, but currently it's the WHO grade 2 astrocytomas and oligodendrogliomas, which are considered to be low-grade gliomas, and the grade 3 ones are excluded from this definition. The grade 1s have also different behavior, so they're excluded from this definition. So these are not a common tumor. These are rare tumors relatively. They account for 5 to 10% of all primary brain tumors, but they generally affect the young. These are the highly productive part of the society. And most of these patients are expected to live long. So balancing quality of life outcomes is very important for this young group of patients. So generally, oligos tend to do well. Median overall survival currently is more than 14 years, and the astrocytic tumors, the median overall survival is up to 10 years currently. As I have said, young patients in their 30s and 40s are mostly affected by these tumors. Seizure is the commonest presentation, up to 85% present with seizure. But there are other rare presentations like local focal neurological deficit for some cases, and some are picked incidentally for instance, imaging them for neurotrauma. I'll present here an example of a rare presentation. This was a patient who was being managed by a neurologist with antiepileptic drugs after presenting with seizures. He was being managed there with well-controlled seizure for around 2 years at a private center. As you can see from his initial image, it shows right middle frontal gyrus low-grade glioma. Presented 2 years later to our hospital with spontaneous bleeding and right-sided hemiparesis. As you can see here, there is acute bleeding in this patient. Underwent successful surgery, and histology was oligodendroglioma. We didn't do any molecular test, so we call it not otherwise specified. Imaging, generally, we rely on MRI with contrast. This is our basic method of investigation. We don't have the advanced imaging techniques. These tumors generally don't enhance. They are hypointense on T1 and hyperintense on T2. On FLAIR, they could have variable signal intensity. Most of them are hyperintense. Some of them could have hypointense cores. So when you see hypointensity, we call it a T2 FLAIR mismatch, and this is highly specific for the IDH mutant astrocytic tumor, rather than the oligodendroglioma type. So advanced images like functional MRI, which could be helpful in surgical planning, are not available here. You could get beautiful images of tract imaging using DTI techniques, again, not available here. You can even do a 3D reconstruction of this tumor's relationship with the corticospinal tracts and motor cortex. This is quite helpful for surgical planning, but we don't have the luxury of this advanced imagings. So the general treatment options are as outlined. Generally, the first-line treatment currently, the accepted one is surgical resection. So we no longer observe these tumors. We have enough ample evidence to suggest that resected tumors do better than observed tumors or biopsy tumors. But in certain patients where surgical resection cannot be done for different reasons and a biopsy should be done in these tumors. A problem with biopsy is that these tumors tend to be heterogeneous, so different areas could have different degrees of grade. So for instance, up to 28% of WHO grade 3s are undergraded into WHO grade 2 tumors based on just biopsy. But you can use metabolic scans to guide these biopsies. For patients who are at high risk, we'll discuss about this later, we have to add radiation plus chemotherapy for most, sometimes only chemotherapy. Nowadays, also in recent years, we have targeted therapies. Vorasidenib is a new agent which targets the IDH1 and 2 mutated enzymes, and this has been approved by FDA as of 2024, and it's going to be probably the way things are going to be managed in the future. Targeted therapy is going to be the way to go. So why do we operate on low-grade gliomas? As I have said, it has several benefits. The first one is it does prolong the overall survival. When you compare maximal safe resections to biopsies or observations, the overall survival is significantly improved with surgical resections. It does also prevent or delay, actually, rather, malignant transformation, which will improve the malignant progression-free survival in these patients. For patients presenting with mass effect symptoms are expected to improve for most, and it does improve seizure control, and improvement in quality of life could be expected with successful surgical treatment. The other benefit with surgical resection rather than biopsy is that you could do a more extensive sampling of the whole tumor rather than a single region, which might undergrade the tumor. And in patients in which you have done a gross total resection, low-risk patients, you can avoid or even, you could delay or even avoid radiotherapy, chemotherapy for many years. Here are some of the landmark studies. This is one of the earliest studies published in JAMA in 2012, comparing two centers, one center preferring to do early aggressive resection and the other one doing a biopsy and watchful waiting. As you can see from the survival curves, that those who practiced early resections did better in regards to overall survival. So now that we have established that surgical resection is the way to go for these lesions, what is the cutoff point where surgical resection starts to benefit the patient? And what is the threshold? Is it 10%, 20%? How many percent of resection does benefit the patient? So in general, the agreement is that we have to do a more aggressive resection, but we don't know the exact cutoff point where the benefit starts. And different studies, as outlined here, have shown different threshold for extending the overall survival in these patients. This could be based on the percentage of extent of resection. The lowest that I could find on the literature was at least 40% resection, and it could be based on volume. This is more better way of evaluating degree of resection. So if the residual is less than 15 or 10 cc's, based on different studies, there seems to be an improvement in overall survival. So generally speaking, based on one of the largest surgical series, we have to aim for more than 50% resection or less than 10 cubic centimeters of residual in these patients to benefit from resective surgery in regards to extending the overall survival in these patients. Next, we'll outline when do we consider biopsy rather than resection. So not all patients are going to be good candidates for resection. So a minority of them might need to go a biopsy procedure rather than a resection. And this is based on both tumor characteristics and patient characteristics. So tumors crossing the midline with extensive involvement of both hemispheres, the so-called butterfly gliomas, are sort of like poor candidates for resective surgeries, although recent studies have shown that they could be resected safely using cortical stimulation and subcortical stimulation mapping. Tumors involving more than 3 lobes. Previously, we used to call these ones gliomatous cerebri, and not causing mass effect. These are poor candidates. This is a very diffuse disease, and biopsy should be done rather than resective surgery. Sometimes at recurrence, we're not sure whether that's recurrence or pseudo-progression, so it might be wise to go with biopsy first rather than going for resection surgeries. In regards to patient characteristics, so patients who are very advanced age and they're not expected to live long, and then you might skip, resective procedures in these patients. Patients who are poor anesthetic risks because of poor KPAs or having severe cardiopulmonary comorbidities should be biopsy rather than resected. And finally, patient preference should be respected, because even with resection, using mapping techniques, it isn't going to be 100% safe. So there is still a 3% chance of causing permanent deficit in these patients. Now, to do a successful surgery, certain adjuncts are required. The most important adjunct is brain mapping. You cannot do without intraoperative brain mapping. This is something we're lacking here. Currently, the surgery is being done based on functional mapping. Intraoperative MRI, although a useful tool, still you can do without it because, anatomy guided resection with intraoperative MRI, although it does extend the extent of resection, still could have a higher rate of complications using this one because you're not doing mapping. So around 30% will develop permanent deficit using this technique, but if you do brain mapping, only 3% deficit. Now, intraoperative ultrasound is very good to help us navigate intraoperatively. It is real time. It doesn't change with brain shift. So this is a very important cheap tool. Neuronavigation is kind of useless except for planning, the craniotomy because of the brain shift. Its use becomes less and less helpful, and studies have demonstrated that it's of little use in managing these patients. And finally, a little bit about fluorescence-guided resections. These are good for high-grade lesions because they do fluoresce in more than 88% of grade 3 and 98% of grade 4 gliomas, but in grade 2s, only 40% fluoresce. So generally, they're not used to guide resection. Now we'll go through some of the lessons we have learned in managing these patients in our local practice. So our setup in the earlier years, we were using this old Carl Zeiss microscope with no assistant eyepiece, but it's a pretty decent optics, although it has some limitations. Nowadays, we're using the more modern Leica microscope. For intraop ultrasound, we borrow the portable ultrasound machine from our anesthesia group. And then the only problem with this ultrasound machine is not a neurosonogram. We use the linear probe, but the size is a bit big, around 5 centimeters, so it requires bigger craniotomy. Now, the major limitation in our setup is the lack of brain mapping capabilities. I'll show you some of the problems that could arise because of these issues later. As I have said, our ultrasound probe is not an appropriate one, but we can work around that one. We don't have neuropsychological evaluation. This is also a major limitation. As I have said, we could do without neuronavigation, and really we could do without also functional MRI and DTI currently, although they will be quite useful in the future. Now, our guiding principle is to maximize the extent of resection while the safety of the resection is maintained. We practice more anatomy or image-guided resection rather than, the currently accepted function-guided resection due to the lack of, brain stimulation. This is an old technique, which has some limitations. So these are our general considerations when we select patients. The first thing is to see the image and to identify the location of the tumor. Some tumors which involve one hemisphere extensively, butterfly gliomas would be poor selections, but the classic teaching that this tumor resectability will depend on imaging is nowadays out of favor. For instance, you could really resect some multicentric gliomas successfully with improved overall survival. I'll show one case later on. The next is we estimate the percentage of resection that we will be able to achieve in these patients. And if we think we cannot achieve more than 50% resection, we usually might go with a biopsy procedure. And this really depends on the location of the lesion and then the patient's wishes and needs and the technical also ability and also the experience of the surgeon. The other consideration is symptoms. Now, patients with refractory seizures might benefit even with partial resection. So those are going to be good candidates for resection. Patients with symptoms related to mass effects, again, could benefit from a reduction of the mass, and this could lead to improvement in symptoms. We do assess the general medical condition of the patient. Most patients are young, and there isn't an issue in regards to anesthetic risk in these patients, though. And finally, the patient's wishes, needs, occupation really matters. For instance, a patient might not be wishing to risk, fine motor skill functions if he's, let's say, a surgeon versus, a farmer, which really relies on gross motor functions and might prefer to go with surgical resection near the motor cortex. Now, to do anatomic guided resection, the most important principle is to localize the tumor intraoperatively. And anatomy is the way to go for this, and there is no technological replacement for microneurosurgical anatomy. And we really have to understand the relationship of the tumor to normal anatomy in regards to the craniometric points over the surface of the skull, and we have to understand the relationship with the cell key points We have to understand gyral and sulcal anatomy involved by the lesion, and we have to understand also the tracts that are potentially involved by the pathology. So we need to know the normal anatomy and also how the normal anatomy has been affected by the pathology. Here we can see the different, the cadaveric dissection showing the different lobes of the brain. You have like the U fibers superficially, and then you have the deep association fibers at the deeper resection. If you dissect deeper, you will find the different projection fibers. And before each procedure, you have to revise this loco-regional anatomies. And the different sulcal key points, sulcuses and gyri have a known relationship with the different points in the cranium, including the bregma, superior temporal and coronal suture. So these craniometric points are very helpful in designing the craniotomy and guiding the resection. Now, the other thing is that we have to understand is how gliomas grows. This really helps in designing the surgical procedure itself. So generally, early on, gliomas do limit themselves to the gyrus of origin. They respect the white matter tracts, although, there could be some gliomas could be more invasive, extending up to 2 centimeters, with what can be seen by imaging. But the general growth pattern is first to stretch the white matter fiber tracts around them. Now, as the tumor grows, the preferred way of spread initially is towards the ventricle. This is a very helpful information, during resecting. In most of these tumors, which reach the ventricle, we like to open the ventricle to confirm that we have achieved good degree of resection. And this is followed by growth along, the gyrus itself of origin. Once this gyrus is expanded, the next advanced stage of growth is to jump into the next adjacent gyrus. And, at a later stage, the tumors could cross along the midline using commissural fibers and involve the contralateral cortex. And the origin is quite variable, most likely to arise from subgyral and subcortical regions. The limbic, paralimbic systems are also a preferred location of origin for these low-grade gliomas. The other important point is to use fixed points. We don't have neuronavigation, but we can use these fixed points which don't change for intraoperative surgical navigation. So if a tumor is near the falx or tentorium, we use that to measure the distance from falx to tentorium, the amount of cortex that we have to resect. We use sutures, location of bridging veins, other cortical vessels are useful landmarks in resecting these tumors. And the other is to understand how the cortical structure is changed by the tumor itself. Some tumors widen the gyrus. There could be color change within the gyrus itself. Cell size could be, effaced, vessels could be stretched. So this is a good telltale sign to identify where the tumor is located. And the other is the tumor itself. Once resection is started, a color is a helpful guide. Most of these tumors have gray consistency, pale to gray consistency, but at the edge of tumor resection, they are very difficult to differentiate from the white matter. So this tends to be less helpful when you reach the edges of these tumors. And the tumor consistency is quite variable from the feel of the white matter. And also the response to bipolar suctioning of the tumor is different from the white matter. This is an image to show you the different techniques that we can use. This is measurements being done from the falx. This is a tumor involving the superior frontal gyrus. The vein also could be a useful landmark. I'll show a video later how we use the vein and the falx and the location of coronal suture to localize these tumors without the use of neuronavigation. Some tumors do change the cortical appearance, as I have said. You can clearly outline this tumor, but others don't change the cortical surface, since most of these tumors arise from the subcortical region. The other important consideration is to measure some more, I would say. Now, once you have identified these landmarks, which are fixed, like, as I have said, the falx, tentorium, and sutures, you can measure from these fixed lines to map out the extent of resection that you're going to do. And the depth of resection is a bit hard, but generally you can measure this as well, and by comparing it to the imaging findings, you can terminate resection based on the depth that you have measured on the imaging. And finally, the use of intraoperative ultrasound cannot be really underemphasized, because it's a very helpful tool in these resections. In this case, you can see this is a clearly, pathological tissue. There is no problem in localization, but, at a deeper extent of resection, ultrasound could really guide extent of resection in these tumors. When we use ultrasound, since the probe is large, to know where we are actually, we put a micro dissector between the brain and the ultrasound probe, and this micro dissector does cast an echogenic shadow, which can really help us map, the extent of the tumor by moving, this micro dissector along the probe, and then we can map out the extent of the usually hyperechoic tumor. Finally, we have to put all this information that we have gathered from the imaging pathoanatomy, from the craniometric cortical relationship, from intraoperative measurements, ultrasound findings, and tumor characteristics together to effect the successful resection of these lesions. Here is an example. This is not a low-grade glioma per se. This is a DNT case, but it's small enough to help us, we demonstrate some of the technique. The technique is going to be the same that we use for low-grade glioma resections. So you can see that this tumor is located in the middle temporal gyrus, the posterior aspect. This is a superior temporal. This is the inferior temporal gyrus. And there are important landmarks. Now on the anatomic model here, I have outlined the potential location of the lesion. On the skull, there are areas that we can map, to expose this tumor and to know where we are. The first important landmark is going to be the posterior limit of the superior temporal sulcus. And this could really be mapped on the skull. In this location, we take the connecting point between the squamous cell suture and the parieto-mastoid suture, where these 2 points meet. If we measure 3 centimeters above, this will correspond to the posterior limit of the superior temporal sulcus. We call this the posterior temporal point. So this could be our posterior landmark of our craniotomy in this patient. The other important landmark in this case will be the inferior Rolanic point, which could be really outlined as the superior squamosal point. And on the scalp surface, this is going to be around 4 centimeters from the tragus. This will be the anterior limit of our craniotomy in this patient. And then the next stage is going to be to identify the relationship of this tumor to the deep white matter cortex, the deep white matter tracts. So as you can see in this anatomical model, there are different white matter tracts which are going to be related to this lesion. Some of the most important ones are going to be the optic radiation, tapetal fibers, not that much important in this resection, and they're very deep. On the surface, the IFOF would be also related to this lesion. But as you can see, this lesion is limited to the level of the sulcus. So most of these long association fibers are going to be located deep to the sulcus. So the only thing that's going to be resected with the tumor, if resected, is going to be only the short U fibers. Next, we use, as I have said, local landmarks. In this case, we have the advantage of using, for instance, the posterior aspect of, the petrous ridge, which can be exposed at the inferior limit of the craniotomy. We can measure from that. We can use this vessel and measure from that. This vessel, again, very good important landmark for intraop resection. And finally, we complement this with intraop ultrasound and can achieve a very good resection, as you can see in this post-op image, with preservation of the important structures. Other important aspects of the resection is, now that we have localized the lesion, okay, how do we resect the lesion is the most important aspect that we will discuss next. So for most resections, suction bipolar is actually adequate. And, CUSA could actually have a downside. If you're using cortical mapping, for instance, CUSA or Cavitron ultrasonic aspirator could actually temporarily disrupt, affect cortical mapping. And CUSA could be quite dangerous in pial surfaces because, there is more chance of injury to the pial surfaces rather than with CUSA rather than, using the simple suction. We generally like to use higher bipolar setting when we are away from, blood vessels and pial surfaces, because at higher bipolar setting, the response using this technique near the pia. And when we're dissecting vessels, we like to use sharp dissection. And generally, if you have disconnected a certain cortical region, it can be removed safely to maximize resection. But take this under advice, because brain mapping is usually required to say truly this cortex is disconnected. For instance, if you are resecting a tumor and you have undermined the superior cortical surface, as you can see here, and you have reached the pial surface without causing any deficits, this cortical tissue sitting above could be safely resected and could help maximize the extent of resection in these patients. We generally use the subpial technique, and near pial borders we don't use bipolar, we just use suction, and if you have bleeding you can use irrigation, and you can just put cottonoid to control some oozing from the pial surfaces there. Now this helps prevent devascularization of the adjacent and involved gyri. The cell size are usually your anatomic boundaries for resection. And also we can use this to skeletonize blood vessels like bridging veins safely. So you have different techniques for resection of intrinsic lesions. Generally, as I have said, the subpial is preferred. If you go sulcus to sulcus, there is high chance that you could injure the vessels supplying the adjacent gyri while dissecting, and it could cause also vasospasm with that technique. Now, the blood supply of these tumors usually come from the cortical branches. A few of them could get, branches from deep perforators, and you have to sacrifice individual vessels supplying the tumor and preserve the impassant vessels. Otherwise, you will end up in different degrees of infarction in these patients. Now, for the most cases, the resection, the traditional way of doing these surgeries is to go inside, work your way into the outside by using suction and bipolar. But I think this takes longer time, and there is more chance of leaving tumor residual with this technique, and it could cause more bleeding. So we prefer to go at the edge of the tumor with the junction with normal tissue, and then start making this cortical and subcortical incisions and remove the tumor more or less in an in-block manner for most cases. Now, this might not be done for all cases. For instance, in insular gliomas, you cannot remove them like that. You have to do inside-outside technique, because you have to work between the different M2 branches. Now, in areas deemed to be safe, in non-eloquent areas, you can extend the resection up to 2 centimeters. This is what we call a maximal resection, as demonstrated on this image. So the definition of supramaximal resection or supratotal resection is, in glioblastomas, you remove the enhancing and the flare hyperintense lesion. But here, the tumor is non-enhancing, it's only flare hyperintense. So definition is to go at least up to 2 centimeters beyond, what is seen on imaging. And studies have shown that this tumor actually infiltrates way away from what is seen on imaging, up to 2 centimeters. And by doing this, you could really delay malignant transformation in these patients. The use of awake craniotomy is a bit limited in our setup due to the lack of brain mapping, but it could be quite helpful when operating near eloquent regions, because it gives you the confidence actually to cut into these eloquent regions and do the resection. And if you cause deficit, you could really limit the extent of deficit in these patients by terminating the procedure. Here is a case to demonstrate such a resection. This is a left inferior parietal lobe tumor, also involving part of the Wernicke's area in the posterior superior temporal gyrus here that you can see. We examine both the motor because, while doing the anterior resection, you could really transgress into especially at the white matter level, into the corticospinal tracts. And we do assess language parameters while doing the inferior cuts. And you can achieve almost, in this case, a near total resection. There are sometimes post-op changes that you can see, but most of the residual that we have left is in the superior temporal gyrus, where we thought, where the language area might be. Now, I will do a video demonstration to tie up all the principles that we have talked about. This is a right frontal glioma. It does involve mostly the superior frontal gyrus. It does reach the ventricle. And corpus callosum is partly spared, but it does reach the ventricle and has this relationship with the quadrate nucleus here. Our general principle is trying and save the cingulate gyrus, because we have seen patients develop akinetic mutism with resection of this cingulate gyrus. And in severe cases, it could have abulia. So we try to preserve this, whether involved by tumor or not, due to the lack of mapping. I'll go ahead and start the video. So this is checking with ultrasound with a micro dissector. We map the posterior border of the tumor. So we start with the one I'll mark with cotinoid and place a cotinoid. That's the posterior margin. I check from the vein also, checking with anatomic landmarks, and then the relationship of the tumor with the coronal suture. This is a coronal suture. In this case, it should be related to the posterior limit of the tumor based on imaging findings. So I have used three landmarks now. And then I measure to the width of the tumor from the falx. This is a superior sulcus. At the deep level, it does extend a little bit deeper than the superior frontal sulcus. We start the cortical incisions. I'll try to preserve this vein because I believe this vein drains the inferior aspect of the middle frontal gyrus here. We cauterize individual veins draining the tumor, which is going to be removed. Sharp dissection for pial opening is done. Some of the feeders that you can see here are going to be individually cauterized and cut. We go along the vein, making sharp dissection. In this case, we're going to remove the tumor in one piece, and then we're going to maximize the resection at a deeper level. So we use bipolar at high magnification. So next is to undermine the vein. This is the subpial technique I was talking about. This helps preserve the vein and major arteries. So we'll go under the vein. I'm going to try and float the vein away from the lesion. And we'll go on the other side, do the same. Some of the draining veins and feeding arteries are individually cauterized and cut. We use sharp dissection here. So here you can also see individual cauterization of arteries supplying the tumor. I check the depth of resection. I still need to go a little bit more deeper. Now you can see the difference in texture there, right? It's not white, it's a bit grayish because tumor involved region. And then I'll do the ventral aspect of the resection, mobilize the tumor, do the medial disconnection from the medial aspect of the frontal lobe while preserving the cingulate gyrus, final disconnection from the vein. And the tumor could be now mobilized more anteriorly. Here I'm sampling clearly pathological lesions for better representation, although I'm going to send the whole specimen for pathologist. So here the ventral resection will be carried out, immobilizing tumor into the second compartment of the resection below the vein. And an assistant helps with a retractor using a pen field. And we'll remove this big chunk of tumor, and then we'll further remove this pathological tissue using suction mostly. Check the depths. I still need to go. These are calibrated cardboard cuts, sterile cardboard cuts that we use to check the depths. And then I resect more. Now I'm satisfied here. And this is a vein that the landmark that I measure for the depths. In the posterior compartment, next, I'm going to check. So it seems to be still some tissue that has to be removed. Here you can see an artery which was preserved in a mostly subpial fashion, again maximizing the resection. This is a medial aspect, doing a subpial, preserving the pia of the medial frontal gyrus. Now we have opening to the ventricle because this tumor reached the ventricle, and you can see the head of quadrate. And then we can remove, following this, roof of the ventricle to maximize the resection, more tissue. Here it looks like a white matter, but this is tumor involved based on imaging parameters. So you have to do very good hemostasis, prevent blood soiling the ventricles. We cover the ventricle with cotinoid while working to prevent blood from seeping into the ventricle. Now that's the head of the quadrate. We're more or less now done with the resection. Final check of the opening into the ventricle. And then next will be to do hemostasis. So we're checking the extent of resection using these calibrated cardboards. We fill the ventricle with normal saline, block it with Surgicel, apply Surgicel to pial cut areas. And that's the end of the resection. This is a post-op image. There is going to be some post-op change, which will, if you take a delayed image at 1 month, 2 months, some of this will improve. Clearly, we have left the cingulate gyrus alone. This is, although it's tumor involved. So you can get a very satisfactory resection with this, and patient didn't have any complications. Now, how to avoid complication? So certain complications are transient, and truly they can be accepted to maximize resection. But the patient really has to be informed about this, especially when you're resecting near, for instance, the supplementary motor area. SMA syndrome is quite common, but the patient usually improves within a few weeks to a baseline function, although rarely, it could have some lingering deficits in these patients. The other is to respect anatomic boundaries, sulcal boundaries, gyral boundaries have to be respected. You have to respect elegant areas. And uninvolved neurovascular structures in passage arteries have to be preserved. Veins, very important to preserve. You have to use SAPIAL technique and intraoperative tumor localization using the different techniques that I have outlined is quite important to decrease the complication rate in these resections. I'll say a little bit about the place of molecular genetic testing. Generally, currently, molecular testing should be done for all tumors. Because classical histology is not reliable. I'll show you such an example. This is a patient who presented to us in 2021 with status epilepticus, a 26-year-old female patient. You can clearly see the T2 flare mismatch, although initially our colleague thought this could be a cystic part of a tumor. She underwent surgery, and intra-op was noticed to be solid, and a partial resection was done, and surgery was terminated because of an anticipated solid lesion. Now, 6 months later, the histology says pilocytic astrocytoma, so it was decided to observe the patient. But 6 months later, she again presented with status epilepticus. And you can clearly see now involvement of the anterior insular gyrus and the frontal operculum. This is a surgical artifact from previous partial resection. You can clearly see this is not a pilocytic astrocytoma based on the imaging. And then we went ahead with second surgery. We did a near total resection. As you can see, there are these T2 hyperintensities. These are artifacts from surgery. I'll show you the later image that was done. But this is a residual that was left at the head of the quadrate. Other than that, she did well. There was no complication. The 1-year scan was reassuring. There is that small, residual here. Other than that, there is no other tumor in the surgical bed. And at 1 year, we did the EEG was normal. We stopped the phenytoin after tapering it. But 7 months later, she presented with new onset focal seizure. She didn't have focal seizure initially. And we took an image, and you can see recurrence of the lesion in the posterior insula. And
Dr. Sami, I think we lost you.
It's okay. He'll come back on, hopefully. Sometimes there's a little hiccup. He might have to reboot. He'll reboot and come back, and it'll be
we do have
hopefully.
Yeah.
Of course, you go into a panic when you're presenting. But once your senses come back, and then you re-enter.
Yeah, he is quite experienced, so I think he'll be okay. But I guess we have to wait for him for a couple of seconds here. I think meanwhile we can all of our presenters. Thank you so much for being here. Dr. Sam, I think he's trying to fix his audio. Meanwhile, all our participants who have questions for both the first presentation and the second presentation. You can go ahead and put your questions in the chat box, or later on we can have the Q&A session where you can unmute yourself and have the discussion. We're just gonna have to wait for a couple of seconds for Dr. Samuel to fix his presentation and come back to us.
Yeah, perhaps we can have the most senior here, Dr. Lenzino, if he has any comments so far.
Yeah.
So Dr. Lenzino so far?
Well, I'm here as a student, and first of all, I wanted to congratulate the presenters. They've shown us that medicine and neurosurgery is not done by the walls; it's done by people. And as we have seen, you can have great medicine in different parts of the world. As a comment, I like to say that, and I'm old enough that I learned a lot of tricks 40 years ago when I started, when we did not have a lot of the current tools. So as a general comment, I want to stress the fact for the young colleagues on the webinar that quite often you can turn obstacles into opportunities, and you have seen in these presentations how really the conditions under which you work, they really force you to utilize to the maximum anatomical knowledge, anatomical correlations, and a lot of practical, useful pearls. I see Dr. Sam is back on, and we'll let him conclude.
Okay, Samuel, thanks for coming back.
Thank you. I have some issues with the connection.
That's okay.
I think we stopped here. This slide, right?
Yes, I think we did.
All right. Okay. So we did a BRAF test, which was negative, which was supposed to be more positive. It's positive with pilocytic astrocytomas. We went and ruled out that one. And then we did IDH mutation. It was positive for IDH1 mutation, and 1p19q was negative. So we had this diagnosis, IDH mutant, diffuse astrocytoma, WHO grade 2 at this time. But since it was growing fast, we had a suspicion that this might have undergone malignant transformation. So we discussed with the patient. The patient wanted to go abroad for further treatment, but didn't succeed with that. She came back after 6 months. At this time, you can see very rapid growth with some areas of enhancement. So the suspicion was that this tumor has clearly transformed. And clinically also, she had this poorly controlled focal seizure, suggesting that there is significant progression of the lesion. And then we decided to go with surgery, discuss the risks. Patient didn't want to risk homonymous hemianopia. So we had to leave the posterior aspect of the tumor over the temporal lobe. We did a reasonable resection with anterior mesial resection in this time because all the limbic, paralimbic structures were involved. Ended up giving her a perforated injury, as you can see here, mostly a basal ganglia infarction, which she tolerated very well. She had only mild transient hemiparesis, which resolved after 1 week, and some behavioral issues which resolved after a few weeks. While waiting, again, the other problem is, these patients of ours don't get radiation and chemo immediately because of waiting list. While waiting for chemo radiation, you can see significant progression of the lesion. Now it has started to enhance actually significantly. She finally got the radiation, continued on chemo. You can see clear resolution with chemo radiation of the enhancement. And this was her most recent image in March, after 1 and almost half year after her last surgery. Clinically, she's asymptomatic, seizure is well controlled, and the disease seems to be stable and she's doing well. So the lessons that we learned on molecular testing is that never rely on classic histological examination. Tends to be quite unreliable in my opinion, and you have to correlate histological report with the patient clinical and radiological finding. If they suggest pilocytic and if the tumor doesn't look like a pilocytic, you have to question that and ask for a second opinion. Okay, so what tests do we send for this lesion? Because these tests are expensive in our setup, and most of them are done abroad. So we do it in a stepwise fashion. So starting from the most likely diagnosis and then to the least likely diagnosis if the diagnosis is not captured during the first test. So the first test that we do would be to assess the IDH mutation status. If it is mutated, then it is by definition IDH mutant astrocytoma. Next, we usually skip ATRX. We just do 1p19q codeletion. If this is codeleted, there is an oligodendroglioma. If it is not codeleted, we might ask for a CDKNA to AB status, which is usually not available. If this is, shows homozygous deletion, it means it's a grade 4 astrocytoma, which is treated differently. Now, if this is retained, it is a grade 2 astrocytoma. So following surgical resection, adjuvant therapy is recommended for high-risk patients. For us, if we don't do a gross total resection, if the patient is above 40, if there are neurologic deficits, we go with radiation therapy followed by chemotherapy. For some, we might delay radiotherapy by giving just chemotherapy with either PCV regimen or temozolomide. The follow-up, so the first scan is done early within 72 hours. We don't use contrast in the first scan because these are non-enhancing lesions. We assess the extent of resection. In some patients, you might have to do a second look surgery. And after that, the next scan is going to be done at 3 months. This one is with contrast, and all the other images which are going to be done every 6 months are going to be with contrast. Some patients require rehabilitation, speech therapy, physiotherapy. Some require psychiatric, psychological help, and seizure therapy is quite important in these patients, and they have to be linked with the neurologist. One peculiarity that we have noticed is that immediate post-op scan tend to have artifacts. As you can see here, this patient didn't receive any adjuvant therapy, but you can see the flare hyperintensity seems to have reduced and stabilized at 2 months scan. So this is the real actual baseline rather than this image. Now, the way I see it, we need to have some improvement to maximize our extent of resection and prevent, some complications in these patients. Most important thing that needs to change in our setup is to start brain mapping. So we have to move from anatomy-based to function-based, neurosurgery in these patients. Since, the classic imaging does underestimate the extent of these infiltrative lesions. The next most important thing is, to optimize radiotherapy and chemotherapy services. Nowadays, we have a couple of centers offering this therapeutic modalities. And the last one is to establish a very robust molecular diagnostic neuropathology service. So as of this year, we have a new LINAC machine at our center. So that's going to be a game changer for us, I believe. And most of our patients could receive timely radiotherapy. Here, I would like to show a few cases if time allows us, or we can terminate the presentation here. But I have some few interesting cases if we have the time.
Dr. Bennett, I think it would be nice to see these videos. How much time do you think we have in this session?
Sure, as much as you want.
All right, great. Dr. Sami, you can continue.
All right. So I'll start with this interesting case. This is a very giant tumor. It's more diffuse than compact. Some tumors are more compact, others are diffuse, involving the dominant hemisphere, mostly the left frontal gyrus, including the cingulate gyrus is involved, corpus callosum is involved. There is a relationship here to the ventricle and quadrate. It's calcified, suggesting, mostly oligodendrogliomas are the ones which are calcified. There is an important relationship here to the motor area. This is a precentral sulcus, and you can see it's abutting the motor area. A positioning is standard supine with head slightly, flexed and head of bed is elevated 30 degrees. Craniotomy has to be very large based on craniometric points. We'll go ahead with the operative videos. We do our measurements as I have shown and then do the cortical resection. I'll skip this part. Once the cortical and then subcortical disconnection is done around the tumor, we'll see some of the techniques that I have demonstrated earlier. And the medial aspect of the resection, we respect these big veins. Tumor is removed in big chunk. This is a frontal basal region. We preserve the orbitofrontal cortex because it's uninvolved and it's quite important region for higher functions and in processing of emotions. So it's removed in 2 big large chunks. Next is to expose, as you can see here, the frontal horn. This is a very important landmark. The tumor does reach the ventricle. We open into the ventricle, block it with cottonoid to prevent blood from seeping in. Next, we widen this opening following the landmarks that we have identified. So I know the extension of this tumor over the roof of the ventricle from the anterior tip of the frontal horn. So this is a septum pellucidum. You can see the quadrate. I'll show you near the foramen. This is a foramen of Monroe region. Now maximizing resection around the ventricle, doing this cortical resection along the roof of the ventricle. Next, I'll expose the callosomarginal and pericallosal arteries to know the depths and preserve the cingulate gyrus. These are the pericallosals, and this is the pericallosal. This is the callosomarginal. You can see the corpus callosum there. This helps me know the depths of the resection as well. Next, I preserve the callosomarginal and remove the mesial frontal lobe, preserving the cingulate gyrus here. This is a sped up video. So further removal, we're gonna go subpial, again, maximizing resection here. And I measure from the frontal horn to check that I haven't left tumor here. I remove more tumor here. Checking the opening into the ventricle. This is a tumor involved part of the roof of the ventricle. Checking there is no blood in the ventricle. Cover it with cottonoid to prevent blood entering there. Checking the vessels, no vasospasm. And then we conclude the procedure. Check with ultrasound lastly to make sure there isn't any residual or blood in the ventricle. Get this clean bed and we come out, and the post-op scan shows a near total resection. You can see the most difficult part of this resection is going to be near the motor cortex because, this requires cortical mapping, but I think we have achieved a reasonable resection without straying too far into the motor area here. The cingulate has been preserved. Although we have preserved the cingulate, the patient did develop mutism, which lasted 1 week and completely resolved. He had hemiparesis, which improved within 1 day post-op. The second case is going to be an interesting case involving the insula, paralimbic limbic structures, orbital frontal regions. You can see involvement of both the temporal, neocortical, and mesiobasal regions here, the hippocampus, parahippocampus. The position is standard. The extension is very important to do the mesial resections. We do a large craniotomy. I'll go ahead with the video. This is opening the dura. So this is a Sylvian fissure, temporal lobe, frontal lobe. First, we'll start by resecting the temporal lobectomy. We do an anterior medial resection. So we'll go ahead, measure the amount of posterior extension of the neocortical resection. I'll fast forward this one. We do neocortical resection, identify the hippocampus here. So once the hippocampus is identified, I stop the surgery here because the level of the hippocampus is a good guideline to know the depths of, I'll go back maybe to the image here. If you go on the healthy side here, the level of the hippocampus is a good landmark for the medial limit of the insula here. So I use this as a guideline to measure the depths of resection here. I'll go ahead with the video. All right. And then maybe okay, this is what we have discussed. Next, I'll open the Sylvian fissure, identify the M2 branches, M1 branch. The M1 branch is a useful landmark to do the mesial resections, and then remove the subpially, the superior aspect of the temporal gyrus, identify the M2s, uncover them systematically, do some measurements to extend the posterior temporal cut. Now I measure here from the M2 bifurcations, So this is a good landmark based on imaging. I know how much posterior I have to go to take out all the tumor from the insula. So you can see here is the M2 bifurcations there. And then exposing the superior limiting sulcus, which is an anatomical landmark. Then we enter the insula by removing the short perforator supplying the insula. We have to make multiple channels. Biopsy is taken at different levels. First, we work between the two large branches. Here, since we have done neocortical resection, really helps us remove the insula. So we work between the vessels systematically, preserving the long perforators and M2, M3 branches. Some of the posterior branches are quite useful for motor function, so they should not be injured. And then we open through the superior aspect of the anterior insula. You have seen working between the vessels. Maybe I'll fast forward it. Removing the posterior insula here. The danger is injuring the corona radiata. If we have mapping, you have to do mapping. We have to preserve these vessels. These are very important. They supply the corona radiata. And the response of the tumor to the bipolar is quite different. You can see it grayish and emulsifies quickly. So this is the maximizing the insular resection. I'll forward working again between the two MCS here. I'll fast forward it. Once we're done with the insular resection, next is to do the mesial temporal resection. We follow a subial plane to preserve the structures in the ambient cistern, undermine the hippocampus there. And here is the posterior communicating and PCA vessels there. And we can really cheat and see, behind the tentorium. This is oculomotor nerve, to know where we are. Next is to identify the ICA, follow it up to the MCA. So ICA bifurcation or M1 could be used as a landmark to do the amygdala resection. So I identify the inferior choroidal point here. So a line connecting these 2 points would delimit the amygdala resection. This is an intralimbic gyrus, which should be also removed. So this is an inferior choroidal point there. Once the amygdala resection is done, the next will be to remove the hippocampus in block. Again, this is just undermining the hippocampus. I'll forward it. So we do a cut at the fimbria fornix, and then we remove the hippocampus in an in-block fashion in this case. So this detaching at the fimbria, do a posterior cut then of the hippocampus, and the hippocampus is removed in block. And part of the parahippocampal gyrus is again further removed. This is a tail of the hippocampus, which is removed to improve the seizure control as well. We block the temporal horn atrium connection to prevent blood from entering into the ventricle. All right, so by the end, hemostasis secured. We're satisfied with our resection. And this is a post-op image. Clearly, there is a residual here, which we thought will be unsafe to resect based on anatomic landmarks. There was no complication post-operatively. The histology was oligoastrocytoma. We didn't have molecular testing on this patient due to affordability issues. Here, I can clearly see the extent of resection. This is a pre-op. This is a post-op, including the extension of resection into the tail of the hippocampus there. This is a good degree of resection. Patient underwent radiotherapy, and she is on maintenance chemo. You can see the improvement in the residual with chemoradiation. You still have this signal changes near the basal ganglia that we left. 1 year post-op follow-up, looks stable disease. Okay. The other interesting case is multicentric gliomas. These are supposed to be unresectable in the old days. This is a 24-year-old female patient presenting with seizure. This is a very huge mass causing mass effect. You can see ankle herniation. The midbrain is really compressed here, although her symptom was mostly seizure. She had also additional left frontal, low-grade glioma here. So she had 2 tumors. So since this was a dominant hemisphere lesion, we went with awake craniotomy. We were able to achieve near total resection. I would call it actually a more radical subtotal resection. So we left Tumor involved superior temporal gyrus in the posterior aspect. And you can see here the central sulcus. And this is a landmark, really, the inferior Rolandic point. So anything behind it is the Herschel gyrus and the language area. And this is tumor involved, but since we don't have stimulator, we have to leave this one behind. And you can see clear reduction of the ankle herniation with improvement in the mass effect there. This is the residual that we left on the flare. Now, 2 months later, we went with second stage surgery, and this was a very straightforward removal of the, the frontal superior frontal gyrus tumor. Almost the gross total resection was done here, and patient did very well and was sent for adjuvant therapy. Another interesting case, this is an SMA tumor with extension to motor area, presented with seizure, young patient. We discussed the case that there is a risk of weakness. We went ahead with awake craniotomy. Now I'll demonstrate here that our awake craniotomy, since we don't do mapping, doesn't prevent us from having neuro deficits. During surgery, patient developed more weakness, and we had to terminate the surgery. You can see that we have transgressed into the motor cortex, especially at the subcortical level. He did have right side hemiparesis post-op. 3 months evaluation, the weakness has improved, but he still had some residual fine motor skill deficits, which he was not bothered with because he was a farmer. All right. This is a further image of the same patient. Another straightforward case, some cases tend to be, they show more diffuse involvement. There is a compact region and a very widespread diffuse location. This patient was being followed conservatively by a neurologist, but the tumor did show progression and the seizure was becoming less controlled. She underwent resection under asleep. We did a reasonable resection. She had transient mutism related to SMA syndrome in the dominant hemisphere, which improved after 4 days. And this is a very rewarding resection. You might think some of these areas might be residual tumors, but lo and behold, you see the control scans done at 3 months. There aren't any actually T2 hyperintense lesions, and shows good resection with no post-op complications. Maybe this is our last case, an interesting case again, mostly involving the motor area here and the premotor area. Very high risk procedure. Even pre-op, the patient had hemiparesis. Patient was counseled. We opted for surgery. We did it under awake conditions. We were able to achieve a subtotal resection. The surgery was terminated because he had worsening of left hand weakness. Patient developed that, and we had to stop it prematurely. But post-operatively on follow-up, he did well. He was sent for adjuvant therapy. I think that concludes the presentation. Thank you for listening.
All right. Thank you so much, Dr. Sami. That was a very interesting presentation. Now I'm going to open the floor for discussion. Anybody who has a question, you can unmute yourself and ask your question. Maybe I'll start from Dr. Bennett. Do you have any comments or questions for our team, both for our first presenter and second presenter?
Yeah, I'm not a neurosurgeon, but well put together, good videos, appreciate all the work. And you had one of the most famous neurosurgeons in the world attending here for a while, Giuseppe Lanzino. He's one of the most published neurosurgeons in the world. You can look up his profile, but a well put together presentation. I'll let you take over from here, Jerusalem.
All right. I'll be opening the floor for discussion. Anybody from the participants who have questions or comment on two of the presentation, you can go ahead. But before we go there, the consultant in the first case that was presented earlier, Dr. Samuel, is here. Dr. Samuel, can you comment on the case that was presented, and if you have any tips from you learned from the case?
Okay, I need to have Samuel, can you get off the screen share?
Okay.
Yeah, don't be shy at asking questions. claim your space in the neurosurgery world. No one's going to bite you, but I certainly understand when I was a student, I was very shy. Even one-to-one
Thank you, John.
neurosurgeon.
And
Go ahead, Samuel, go ahead.
Jerusalem. Thank you, Sami. It was an excellent presentation. So just to take us back to the first case, thanks, Semenyo. It was a very nice summary of the case. So there we can think about the options of treatment. So regarding that direct carotid cavernous fistula, one might think, okay, is there a cheaper way of doing this? Can we just tie off or ligate the internal carotid artery? Because essentially that's basically what we did during the surgery. So I'll just pose that question for the audience. And in the meantime, we can also discuss the option of treatment that we selected. How were we able to confidently block off the internal carotid artery? By as you know, that risks a large stroke, particularly in the dominant hemisphere. So Semenyo, maybe you'd elaborate further on the second point, why we were able to close off this carotid artery completely, safely.
You hear that question,
Dr. Semenyo? I think he's here. Right?
Samuel?
No, that was for the first presenter.
Oh, okay, from the other presentation, okay.
Yeah.
So for our patient, clinical presentation was like she was having proptosis, and it was clearly from the CT angio as well as from digital subtraction angiography. It is clearly show carotid cavernous fistula, and there was a clear communication retrograde flow toward the superior orbital vein, and there was we categorized on the right common femoral arteries, and it was used 3 coilings with 20 by 65 and 14 millimeter by 4 centimeters. And after we easily coil transarterial coil embolization, so on the last flow, after we coil embolization, the patient was having almost, it was completely block the lateral flow or the fistulas of the internal carotid arteries with communication to the cavernous sinus. So we used only 3 coils, and it was easy. It was done by Dr. Samuel. And a patient was, as we see from post-operatively, she was having complete improvement from the pre-op. As we see this image, she was having significant proptosis, and currently, almost after 3 months, the patient was having significant improvements of the proptosis.
Yes. So can you please take us back to the right ICA injection on TSA?
Yeah. So
yes. So for everyone who's listening, so you can clearly see the right ICA supplies both hemispheres, and you don't really need to do a stress test like a balloon occlusion test to determine whether the left ICA can be sacrificed or not. The entire ICA flow dumps into the fistula, as you can show us, please, to the next ICA run. Yes, so the entire flow goes to the fistula. So there is no need of performing an occlusion test to check whether she will tolerate occlusion or not. So the first, to go back to the first question, could we block just the ICA in the neck, ligate it, and call it a day? It's especially in our setup, it's a cheaper way of achieving this. But as you know, fistulas are high flow, especially fistulas such as this one, are high flow systems where, as long as you don't take care of the fistula site from the venous site, the fistula almost always recruits other feeders. Perhaps in this case, if you block off the ICA proximally, it might recruit from the right side, from the posterior circulation, and so on. So it's very important that you close off the fistula side, particularly from the vein. So as we coiled this patient, we started from the cavernous sinus and worked our way back through the fistula to the ICA. So that's just one point I think is worth mentioning. Okay, thank you, Semenyo. So I have posed one question to Dr. Samuel. If you can just read it from the chat, it would be, I'd appreciate it.
Let me check the question on the chat.
Okay, maybe it's gone.
From the chat. Yeah,
maybe it's gone. So I think the audio was interrupted while you're elaborating on the use of high bipolar settings for, I believe, subcortical resection away from the pair. Can you just please repeat that, because I didn't get what you said mostly.
So while doing the cortical and subcortical cuts, so to say, high bipolar is quite useful. Also, while working on insular resections, if you're working also within the tumor, the high bipolar setting is quite useful. So we use on standard cautery machines, if you're not using the microset, around 30, 25 to 30 watts is the power that we use. So the thing is, when you use low coagulation, the response of the tumor and the white matter cannot be as well differentiated as when you use high setting. So in high setting, tumors tend to emulsify, and the white matter tends to stay more congealed. So you can really tell the difference between pathological tissue versus normal white matter. But at the age of resection, still, you could have tumor involved white matter, which looks like white matter, but doesn't have any of those features. So this technique tends to be more useful if you're working within the tumor center itself. Mind you have to avoid cautery at all. You shouldn't use any cautery near sulcal surfaces, and just purely use the suction device to do a subpial resection with the suction. And if you have bleeders, a gentle tamponade with cottonoid and irrigation is all that is needed to arrest these bleedings, because you don't want to cauterize the subpial surface and cause injury of in-passage vessels. I hope that made the point clear.
Yes, thank you, sir.
What kind of hello?
Yeah, we can hear you. Go ahead.
Dr. Simon, I want to know what kind of magnetic field of RMI do you use to follow the white matter in resection?
Sorry, can you repeat the question? I think I lost you.
I said that what kind of magnetic field of MRI do you use it to show white matter in resection?
So we purely use the basic MRI. We don't have the advanced tractography. So, but we have already a knowledge of fiber tracts based on anatomical atlases. And before going to surgeries, we assess the tumor's relation to the expected white matter tracts around the tumor, as I have shown previously. And we estimate the location of the white matter tracts based on that. So the best way to go would have been to do intraoperative cortical mapping, because even if you have a DTI image or a tractography image, it doesn't mean if for instance, on pre-op scans, the tumor seems to involve the tracts, it doesn't mean in actuality those tracts are involved. So DTIs are less sensitive and specific for involvement. So the gold standard should be mapping, which we don't have. That's why I have demonstrated some case examples of deficits happening during awake procedures, because we only pick deficits after happening because we cannot do mapping. So we use basic just MRI, 1.5 Tesla usually.
Okay, thank you.
All right.
All right. Thank you so much for the question. Do we have any other questions from the participants? All right. I'm guessing we don't have any further questions or comments from our participants. So I'm gonna thank both presenters for their willingness to come here and present on our webinar today. And thank you so much, Neurosurgical TV, for the opportunity to connect with everyone else and for webcasting our webinar, our Ethiopian Grand Round on your channel. And that's it. Dr. Bennett, if you have any last words, we would love to hear from you. And I think that would be the end of our presentation.
Well, it's good to see that neurosurgery is alive and well in Ethiopia, the home of coffee. I tell you, I could not have made it through residency without coffee. So I'd like to thank you for that, because getting called in the middle of the night, first thing I do, get a cup of coffee. That would, help my attention span. I don't know if you guys like to do that or not, but quality presentations, you can tell you guys did some work putting it together. Excellent quality video. And Dr. Lanzino, as I told Jerusalem, commented that this is incredible. Lots of useful tricks when you do not have access to the latest technology. That's great. You guys are doing what you can. That's all we can ask, is do what you can, and you'll learn technology as it evolves. I think it'll get more accessible to you and more real, so that your hologram is standing next to me talking about approaches. That day is coming, believe me. We'll be able to talk to holograms about, and Zoom will make the same kind of changes. So the future looks bright. We had very good attendance, almost 40, a lot of people, and we welcome you to televise anytime you want. A good way to do it is you just go out and ask neurosurgeons. A lot of neurosurgeons would love to televise here. You just have to ask them. And when they know it's Africa, you'll get a lot of people that say yes. So anybody, any neurosurgeon on the planet, you'll be surprised. Neiman does a lot of that. They get great webcasts. They talk to neurosurgeons. You'd say to yourself, "Oh, they'll never want to come to my country. They're too big." No, they understand. And one thing that the neurosurgeon has in their DNA is their love of teaching. They love to teach. Not one neurosurgeon in 10 years that I've done these has asked for money. Not one. Can you imagine that? The high level of teaching you're getting, and it's free. I'm just amazed. These guys, you have it in your DNA. I'm sure you guys have it too, that you'll continue on and you'll teach the younger medical students, etc. So anytime you have a broadcast, let me know. Don't be afraid to ask anyone.
All right. Thank you so much, Frank.
Yes, stick around. I'm going to turn off the video and then we can just chat informally, okay? Okay.